Hi, my name is Maly Tiev. I am a nurse practitioner. Thank you for joining me tonight. Today, I'm going to discuss metabolic dysfunction associated steatotic liver disease, or MASLD, and metabolic dysfunction associated alcohol related liver disease, MetALD. Our focus today will be on understanding definition, diagnosis, and clinical management using a case to guide our discussions. As I mentioned earlier, my name is Maly Tiev. I am a nurse practitioner. I'm currently working at NYU Langone Health in New York. I have been in the hepatology space for about a little more than 25 years. Please use this QR code to record your attendance for this meeting. So let's start with our case. Ashley is a 52-year-old female. She is Caucasian. She was referred for evaluation after having abdominal sonogram showing mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She feels well without complaint. Her medical history is significant for PCOS, hypertension, and hyperlipidemia. She drinks about 2 glasses of wine a day. On physical exam, she has smooth, non-tender liver edge, and her medication includes amlodipine, atorvastatin, multivitamin, and milk thistle. Here are her vitals. Her blood pressure is mildly elevated at 140/78, and her BMI is 29. Her lab shows that she has mildly elevated ALT of 46, AST is 55, alkaline phosphatase is about 140. Now that is normal or mildly elevated depending on your local lab. Bilirubin is 1.2, normal platelet counts. She is a pre-diabetic with A1C of 5.9, and her triglyceride is also mildly elevated at 185. So the next important question is, does Ashley have fibrosis? So here is her fibrosis assessment based on FibroScan test. So it shows that she has a liver stiffness of 11.4 kilopascal, and this is putting her in the range of F3. Her CAP score is 310, showing that she has severe steatosis. So here is the new umbrella term, steatotic liver disease. This replaced the old terminology, non-alcoholic fatty liver disease. And this terminology now covers all causes of fat buildup in the liver. So starting here on the left-hand side, you have MASLD and MASH. This replaced the old terminology of NAFLD and NASH. And then here on the third column, you have alcohol-associated liver disease, ALD. And right between MASLD and ALD, you have this new term called MetALD. So here the patient has MASLD plus alcohol overlap. And so this diagnosis is based on the patient having MASLD and how much the patient is drinking. So if you look here on the chart, if the patient is drinking less than 140 grams of alcohol per week for female and less than 210 grams of alcohol per week for men, this patient have MASLD. Now, if the patient drinks between above 350 grams of alcohol for female and 420 grams of alcohol for men per week, this patient is considered to have ALD. If the patient drinks between 140 to 350 grams per week for female and between 210 grams per week to 420 grams per week for men, this patient is considered to have MetALD. And then on the far right, you have your less common cause of steatotic liver disease. So this is your drug-induced liver injury, your Wilson's disease, your patient with LAUD, viral hepatitis C, celiac disease, and finally cryptogenic steatotic liver disease. So because alcohol is really important on how we classify patients, let's take a look at what counts as a standard drink in the United States. So here is a picture of equivalent alcohol content for different alcoholic beverages. So starting on the left, you have your regular beer, which is 12 ounce can, and that is the same amount of alcohol as 5 ounces of regular table wine here on the third picture. And that is the same amount of alcohol as 1.5 ounce shot of liquor like brandy, tequila, vodka, rum. So regardless if the patient is drinking 1 can of beer, a glass of wine, or a shot of liquor, they all count as one standard drink, and they has the same amount of alcohol. Now, this is important because going back to our patient, actually drinks about 2 glasses of wine a day. So depending on how big is her glass and how much she is pouring into that glass, she may actually be drinking about 3 to 4 standard drinks. And sometimes I have patients where they tell me, I ask them, do you drink alcohol? And sometimes they say, no, I only drink beer. And I tell all my patients, alcohol is alcohol, whether you drink beer, wine, or hard liquor. So let's take a look at what happened when alcohol interact with metabolic risk factors like insulin resistance, diabetes, obesity, visceral fat, unhealthy diet, sanitary lifestyle, and genetic. So we see here together, it causes impaired liver lipid handling, leading to oxidative stress and eventually hepatocell death. At the same time, both the metabolic risk factor and alcohol interrupts the intestinal microbiome. So together, this causes this inflammatory response in the liver, and this leads to accelerated fibrosis and disease progression. So this tells us that when you have 2 factors causing liver disease like MetALD, these patients tend to progress faster in fibrosis than if they just have MASLD alone. Now let's take a look at drivers of liver disease and how this affects risk for decompensation within 5 years. So if you look all the way on the bottom of the slide, on the left-hand side, you see disease drivers. So these are cardiometabolic risks. So these are the patients with obesity, insulin resistant, type 2 diabetes, hyperlipidemia, hypertension, etc. And then there's genetic risk where these patients have these type of mutation, such as the PNPLA3 and TM6SF2. These are all associated with steatotic liver disease. And then plus alcohol use, depending on how much they are drinking. So right above the disease driver, you see fibrosis stage 1 to 4 based on transient elastography. And so going to the middle, where you look at the dynamic spectrum of steatotic liver disease, starting with MASLD, and going right above it, you see that patients risk for liver decompensation if they have less than a F2 on fibrosis staging, that the risk for decompensation is quite low. It's less than 1%. However, once they start to develop F2 fibrosis, that risk of liver decompensation increased to 5 to 15%. Now, when we move over to MetALD, looking up right above it, we see that again, the risk for liver decompensation for folks with less than an F2 is low, 1 to 5% within 5 years. And however, it is much higher than patients who just have MASLD alone. And if you look at patients who have greater than F2 fibrosis, their 5-year risk for liver decompensation is double those who have MASLD alone. Then when we move on to alcohol liver disease, we see that the risk for liver decompensation for those folk who have less than an F2 is between 2 to 15%. It is definitely much higher than those folks with MASLD and MetALD, and the risk go up significantly for decompensation after they develop F2 fibrosis, so it's 15 to 50%. So this tells us that fibrosis is the strongest predictor of outcome. However, disease drivers determine how they progress across the spectrum. So detecting that how much someone drinks in clinical practice can be quite difficult sometimes. So a lot of time patients don't want to talk about their drinking habit, or they underreport how much they are actually drinking. So this study was published in Journal of Hepatology in 2022, taking a look at detecting alcohol using biomarkers. So the group looked at any patients who have risk factors for fatty liver, such as type 2 diabetes, those with obesity, poor diet, anyone who's consuming alcohol. And what they did was they assessed alcohol using a questionnaire like the AUDIT-C, plus they collect samples. So they did blood looking at CMV, GGT, CDT, and ANI. They also did alcohol biomarkers, urine ETG and hair ETG. And what the team saw was that a moderate to excessive alcohol consumption in a patient who reported, who would actually classify as NAFL, was about 29% and 25% in those patients who were classified as MASLD. So this tells us that underreporting of alcohol consumption is quite common, and it's important to use biomarkers to assess the patient alcohol consumption so that we can classify them accurately. And the study recommend to do combination diagnostic testing, so hair ETG plus urine ETG, as well as survey. So with that said, I really don't do any of these diagnostic testing in my clinical practice. The reason why is I don't really want to collect anyone's hair. And with urine ETG, that only detects alcohol in a short window of time, so it's up to 5 days only. And then the AUDIT-C survey really depends on the patient's honesty, and a lot of time I really don't have time to do a questionnaire with the patient. So in my clinical practice, I actually do a test called the PEth test, which we'll discuss a little more later. This PEth test is a serum blood test that can be easily done or with your local lab like Sunrise, Quest, or LabCorp. Okay, so there's gaps in the assessment of MetALD, and this algorithm will kind of help guide you on how to classify your patient. So what you want to start with is looking for evidence of metabolic dysfunction. So anyone with BMI of greater than 25, those patients with pre-diabetes or diabetes, anyone with blood pressure of greater than 130 over 85, or they on hypertensive medication. You want to look for those patients with elevated triglyceride above 150, or anyone who's on lipid lowering agents. You want to look for serum HDL level less than 40. Again, anyone who's on lipid lowering agents. And what you want to ask is there isolated hypertension or elevated triglyceride? So if your answer is no, you can classify this patient as having MASLD. If your answer is yes, and there is no evidence of alcohol use, again, this patient will be classified as MASLD. However, if you're not sure, then you can consider doing the PEth test that I mentioned earlier. Now, because steatotic liver disease is based on alcohol assessment, you want to quantify how much patient is drinking in grams per week. And you want to ask them about their drinking pattern. Are they drinking alcohol daily? Or they binge drinking? Some of my younger patients or those patients who works every day tends to binge drink on the weekend. Then you want to consider using the PEth test. So the PEth test is a serum blood test that you can easily do, like I mentioned earlier, with your local lab. Sunrise, Quest, and LabCorp has it. Some local lab also have this test. It takes a couple of days to come back, and it has a wide window, so it can detect alcohol up to 4 weeks. And this is what I use most often in my practice. Now, you know, when you see a patient in the office, many times they're not going to tell you, well, I drink 300 grams of alcohol, or I drink like 150 grams of alcohol. They usually will tell you, well, I drink 1 glass of wine every day, or I drink 2 glasses of wine, or I drink 3 glasses of wine, you know, a week. So so a standard drink would equals to about 14 grams of alcohol. So getting back to our patient, she drinks 2 glasses of wine. So that's 14 grams of alcohol per drink. You times that by 2, so that gives us 28 grams of alcohol per day. I usually round it up, so 30, just to make my math a little easier. So 30 times 7, that gives us 210 grams of alcohol per week. So we look here on the gray, right under alcohol, you see that if a female patient drinks between 140 to 350 grams per week, this patient would consider to have MetALD. So our patient, if she drinks 210 grams of alcohol per week, put her into that MetALD criteria just based on what she's reporting. Now, if patient drinks greater than 350 grams of alcohol per week for women, or greater than 420 grams per week for men, they are considered to have ALD. And then you always want to exclude other causes of steatotic liver disease. Okay. Oh. So getting back to our patients, she did have a PEth test, and it shows that it's 120. So just going back to our previous slide, if we look here on the graph, we see that her PEth test is between 25 to 200, again, putting her in that MetALD zone. So this study is taking a look at the durability of PEth as compared to blood alcohol concentration. So after one single binge drinking, we see that with the blood alcohol level, it peaks at around 2 hours after drinking, and then it slowly comes down, and by 8 hours, the alcohol is no longer detectable. While PEth was detectable for 3 to 12 days after one single binge drinking. Here on the right-hand side, we see that PEth level is not influenced by sex or BMI. So therefore, you can pretty much use this test for any of your patients. So this study took a look at alcohol use in individuals with excess weight, specifically looking for those patients with MetALD risk. So what they did was they screened 659 patients for this study. They excluded 42 patients because the patient did not meet criteria based on age, BMI. Some had hepatitis B, C, previous other liver disease, HIV, and a couple withdrew consent. So they end up enrolling 617 patients. Out of these set of patients, they excluded 284 patients because these patients did not drink or they had missing data. So they end up with 333 patients. Then they excluded 236 patients because they did not meet alcohol consumption criteria as defined here. So female between 140 to 350 grams per week, and men between 210 to 420 grams per week with PEth test equals to or greater than 25. And so they end up having 97 patients who were suspected to have MetALD. So this is important. This is equals to about 15.7% of the patients who were screened to have risk for MetALD. So this tells us that patients with overweight or obesity, alcohol use is pretty common, and unless you screen the patient specifically for alcohol, you may classify these patients. So getting back to our patient, she has hypertension, hyperlipidemia. So here, this is looking at the association on with alcohol on blood pressure based on 32 randomized controlled trials involving 767 participants. And what they saw was that alcohol has a biphasic effect on blood pressure. So at the beginning, blood pressure, they saw a decrease in blood pressure up to 12 hours after alcohol consumption, but after 13 hours, the blood pressure increases. This pattern was actually seen across multiple studies. And so it tells us that alcohol does, long-term use of alcohol does affect blood pressure. And so for our patient, her blood pressure remains elevated despite being on medication. So perhaps if she stopped drinking, maybe we may see improvement in her blood pressure. So just something to think about. Then this study is showing that not only is alcohol impacting blood pressure, but it can also increase the triglycerides. So here, this is looking at mean plasma triglyceride concentration over 10 hours after 2 standard alcohol drinks as compared to water, and we see significant rise in triglyceride among those patients who drank. So getting back to our case, and let's review. So Ashley drinks 2 glasses of wine a day. Her PEth test is 120. Her FibroScan test shows that she has F3 fibrosis with severe steatosis. She has hypertension and hyperlipidemia. So her diagnosis is MASLD, predominantly MetALD, based on these informations. So how do we treat Ashley? So definitely starting with lifestyle modification. You want to recommend the Mediterranean style diet. exercise and weight loss management. She would be a candidate for treatment with Resmetirom since she has F3. Resmetirom is FDA approved for patients with MASLD, F2 or F3. And then as far as alcohol go, I would definitely recommend stopping her alcohol use because she have F3. I tell patients that no amount of alcohol is safe for the liver. So anyone with any level of fibrosis, I recommend that they do not drink. And because Ashley has F3, she is at risk for developing liver cancer. So I would screen her every 6 months with AFP and an ultrasound. So looking at the ideal MetALD definition for clinical trial, definitely need to be based on objective biomarkers to help overcome under-report of alcohol use and to standardize the assessment of recent alcohol consumption and to certify alcohol abstinent if needed. You want to make sure that drivers of liver disease are present. So you want to consider more than one cardiometabolic risk factor and to check to see that hypertension and hyperlipidemia persist after stopping alcohol use. You want to consider exposure to risk factors and that they meet criteria during the last 6 months, 6 to 12 months. So here's the take-home message. MetALD is new definitions, and this takes into the account of MASLD plus alcohol overlap. So if the patient consumes alcohol between 140 to 350 grams and 210 to 420 grams per week for women and men respectively, they would meet this criteria. Then clinical criteria could underestimate MetALD, also ALD. So you want to consider doing alcohol biomarkers like PEth test. And you want to ensure that drivers of liver disease are present, not just alcohol, and you want to reassess for metabolic dysfunction over time as well. You want to consider exposure to risk factors, and criteria for clinical research should facilitate an objective MetALD diagnosis, allowing comparison among different socio-cultural reality. And that concludes our presentation. Thank you for your attention. Please visit the GAP MASLD MASH community network for additional disease state education and risk differ webcasts. Now, if you can and you have time, please scan this QR code to complete a short survey and share your thought on today's presentation. Your insights help us to continue to improve.